I'm going to begin with our land acknowledgement, and then I'd like to say a few words about our residents, and then I'll hand it over to Dr. Berman to introduce our speaker for this morning. So Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. Chio also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. And so on behalf of the Department of Pediatrics, I would like to acknowledge our amazing group of residents and fellows, as well as all trainees elsewhere, for their many significant and valued contributions. In case anyone is unaware, this is Resident Appreciation Week, and residents, we really do appreciate you. As a department and as a hospital, we could not do what we do without you. You are here day and night and weekends and holidays. You provide essential first-line care to our patients and teach your fellow learners and medical team colleagues as well. And you lead important research and advocacy projects. You help to make us smarter and provide better care for our patients and families. And you also keep us young and make this place a fun place to work. So thank you for that. And thank you to our pediatric program wellness lead, and as Toby Odson quite well put this, our unofficial purveyor of fun, Dr. Amy Robinson, who has worked very hard with our education leads and PGME staff to make sure that all the residents and fellows feel the love from all of us. They've organized special collaborative contributions from the different divisions with some fun themes. So on Monday, we had hormonal and inflammatory theme. Yesterday, we had intensive Tuesday. Today is Brain and Blood Wednesday. Tomorrow is Torso Thursday, and we will finish on Friday with Generally Holistic Friday. There might be some competition here as well, so all the better. And so to our residents and fellows, happy Resident Appreciation Week. We really do appreciate you, and we hope you feel the love. With that, I will turn it over to Dr. Jason Berman to introduce our speaker.
Thanks very much, Mona. I don't know about the residents keeping us young. Do they help with hair growth? I haven't seen that that's improved over the last little bit. Well, welcome everyone this morning to Grand Rounds. I'm really delighted to present this morning's speaker, Dr. Devin Singh, who's going to be talking about artificial intelligence in pediatrics as part of our Chio RI Visiting Speaker Series. As many of you are probably aware, digital health, including artificial intelligence, is part of the research strategic plan for Chio. And so Dr. Singh's comments this morning will probably resonate with many of you. Dr. Singh is a practicing pediatric emergency physician at Sickkids. He completed his undergraduate training at the at Western University in Medical Sciences, and then actually went on to work at the Ontario provincial government as a business analyst. He then went to medical school in Australia at the University of Sydney and completed pediatric residency and emergency medicine subspecialty training at Sickkids in Toronto. He also completed an additional fellowship in clinical artificial intelligence. His research focuses on the use of machine learning to solve some of healthcare's largest problems. He's the physician lead for clinical AI and machine learning at Sickkids for the Division of Emergency Medicine, and recently obtained a Master's of Computer Science at the University of Toronto. Most recently, he founded Hero AI, an innovative startup lab dedicated to empowering patients and healthcare providers with artificial intelligence. The title of his talk this morning, Applications of Clinical Artificial Intelligence in Pediatric Medicine. Welcome, Dr. Singh.
Thank you so much for the great introduction, and definitely special thanks to our residents. I was only just a resident a few years back, it feels like, and it's always great to appreciate the residents and make them understand just how critical they are to all of the operations that goes down in the hospital. And so it's an absolute thrill to be here today. I wanted to talk about AI and pediatric medicine, but I thought I would even make it even slightly more nuanced around the translation of clinical AI to the bedside and beyond. As introduced, I am an emergency doctor at Sickkids Hospital, and I do a lot of my research on artificial intelligence and machine learning. And I do have a disclosure, although we won't be talking much about Hero AI today, but I am a founder and CEO of a startup lab called Hero AI. And so I want to start with my journey into clinical AI. And actually, it starts when I was a resident. I remember a particular case that was quite challenging. There was a code blue response, and unfortunately, this patient of ours passed away. And I remember thinking, I was quite junior, so I remember once the code blue went off, I had to sort of stand to the side a little bit. I was doing some compressions, but I was just amazed at how the team was able to mobilize together. And despite these best efforts of what was like outstanding, resuscitative care delivered, it really bothered me that this patient had passed away. And in the M&M reviews and sort of breaking down what had contributed to this adverse outcome, I discovered that there are so many different facets that goes into our ability as both physicians, residents, but also as a health system as a whole that goes into delivering outstanding care. And there's aspects of early intervention and health literacy that were part of this case. And it made me wonder, well, if this family would have known or had some sort of tool to get them into our emergency department, our hospital, could we have had a better outcome? And so I was thinking, maybe I'm going to focus on health literacy. But then, as the review went on, I discovered there was actually a lot of logistical challenges that went into this outcome. This family had presented to multiple hospitals leading up into these days, and this lack of ability to coordinate the care or to recognize that this was a high-risk patient certainly contributed to this outcome. And then there's always challenges with patient flow, particularly in the emergency department where I work. And when things are getting really busy and you're feeling really stretched, you get a bit concerned about the quality of clinical care under these strained resource scenarios. And so as a resident, I felt that this, and as a junior staff, I felt that this was like just quite an overwhelming thing to think through on like, how could I manipulate a system and improve it such that if the same scenario were to happen, we'd have a better outcome. And as I started to come up with ideas, it was then even more overwhelming to realize that whatever we come up with needs to be sustainable. Like, this needs to be feasibly integrated into some sort of workflow, and often integrated into workflows that are currently existing. And so that was quite an overwhelming, stage of my career. And what should I focus on? And I actually stumbled across machine learning. So I wasn't a computer scientist before this, but based on that case, and then me just sort of, trying to reflect, my research is going to solve this problem that really bothered me. I stumbled across machine learning, and I realized that machine learning can really help us connect the dots between a lot of the silos that I was just showing there. And that machine learning can really help us begin to navigate this big data maze of our EHRs, and just thinking around, how do we make sense of such high volumes of data, and how do we know when to act on data streams and whatnot. And then I actually think most importantly, machine learning can help us transcend the traditional silos to which our health systems, but even on a hospital level, we can often be so siloed in the way we coordinate and deliver care and the way that data is processed. Machine learning can help with that, and we can start to sort of break those silos down. Most importantly, what I discovered was machine learning, when done right, can actually really supercharge our ability to deliver outstanding care from a patient perspective, and also from like a healthcare practitioner perspective. And if you think about the reason why we sort of push so hard to spend that extra time to do research, to innovate, to stay a little bit late in hospital, it's really for this, what we're seeing here. We're doing it for our colleagues, we're helping out each other, we're doing it for our patients because we really want to derive the best possible outcomes. And we want to be proud of the care we deliver. And I discovered that machine learning can allow us to do this in a really complicated setting like what you're seeing here in this video. And so if you step back and say, well, what is AI, right? Because we hear a lot about, just use the AI. What is AI? Well, I actually like the definition that IBM has come up with. The WHO has a more healthcare-oriented definition, but I think IBM says it pretty simply, that artificial intelligence leverages computers and machines to mimic the problem-solving and decision-making capabilities of the human mind. So think about what that's saying. It's basically taking in some sort of information, just like how we as humans would walk into a clinical scenario or a dilemma, we'd process that information and we'll make a decision, right? AI is meant to mimic that exact process of ingesting some sort of information and then linking it to some sort of decision or outcome. But note that AI is a broad category, and machine learning is really just one subset of AI. It's probably the largest subset of artificial intelligence, but machine learning is one mechanism of actually, achieving artificial intelligence. And then we also hear a lot about deep learning, and we're going to talk a little bit about neural networks just to demystify what that means. But deep learning is just one of many subsets of machine learning. So it's just a method, it's a type of algorithm or a method for enabling machine learning. And machine learning is one form in which we can sort of achieve artificial intelligence. And so why do we need AI, right? And if you think about the use case of a self-driving car, this is an example of an old Tesla. It's probably impossible, I think I could say, to program, like hard program with certain sets of rules for a car like this to just go out into the wild and drive, right? Because how would we be able to anticipate that there would be people walking here in the street? Like, who knows what they were going to be doing at this time as a programmer? And so really, you use machine learning to be able to build these types of solutions that can be a bit adaptive, that can understand in a general sense what the environment may throw at it and be able to reply and make decisions accordingly. And if you saw in that video, the car started to slow down. But this isn't really about like cool, autonomous vehicles. That same type of technology can help in healthcare. For example, just this past year, we had a drone deliver lungs for a transplant from one side of the city to another. And it made 1.5 kilometers might not seem very far, but with Toronto traffic and just the chaos and knowing that transplant, time is outcome, this is like quite an innovative application where machine learning and AI helps with the stability and the transport of that drone. And so let's step back a little bit and anchor this to a particular use case that's near and dear to my heart. And it's around trying to enable clinical automation in the emergency department with this concept called machine learning medical directives. And this is a partnership that I have with AIM and sort of our strategic vision at Sickkids. So lots of great support from them. And imagine a really common scenario. So here's this kiddo, he looks like he's about 6 to 8 years old. He should be outside playing in the snow, building snow forts, having a good time, but he's in his bed complaining of tummy pain. His parent has to make a decision. Should they come into the emergency department? Should they stay at home? And let's say, he's really wincing in pain. So they're going to come in to the ED. And when they get to our emergency department, there's a typical linear type of flow here where the patient arrives, and they interact with one of our nurses, our nursing colleagues, where they go through triage. So this is where we capture vital signs, we ask a few questions on why you've come, we get demographic details. And so that data is then put into our electronic health record system. And I can tell you a lot of the times, based on that initial set of data that's captured, we know that this kiddo may need an abdominal ultrasound. And the spoiler alert to the case here is this kid does have appendicitis. So he does need an ultrasound. He's going to need surgery. If we wait too long, his appendix may rupture, and then he'll have all the complications that are associated with a perforated appendicitis. And so we know here that the kid needs an ultrasound. And yet, unfortunately, what will happen, because he's relatively well compared to everyone else, right? So what will happen is he might wait on a busy winter's day for maybe even 6 hours, waiting for one of our residents or a medical student or a healthcare provider like me to see that patient and assess them. And so, we do the assessment here, and then we say, oh, of course, we're going to get the abdominal ultrasound, right? It's got pain in a pattern that is consistent with appendicitis. I order the ultrasound, but then it doesn't happen just like that. So I'm probably waiting another 1 to 2 hours, maybe, to get that abdominal ultrasound and to get that result. And you could see how this could take even longer, depending on what's happening in the institution. And so you're getting to now 8 hours on a typical busy day from the time that the patient arrives to the time that we're making this diagnosis of appendicitis. But then there's so much more to happen. There's so many other stakeholders besides the patients and us in the emergency department. We've got the diagnostic imaging techs. And so within this window of time, maybe the diagnostic imaging techs have gone home and now it's on the radiology resident to hammer through all these scans, right? And so there's some logistical issues there by the workflow taking so long. We've also got our general surgery team who might have benefited from a bit of a heads up if they had known that there was going to be a surgical case. We've got the OR that needs to plan rooms, anesthesia, and equipment. And then we've got our inpatient beds that need to anticipate, what are going to be the nursing demands in order to staff the beds that are needed for overnight, especially for these surgical patients. And so our question, could we actually leverage this data really early on in the workflow to feed into a machine learning algorithm, or just somehow build an artificially intelligent system that would automate the ordering of that test? Given that I, as a healthcare practitioner, can look at that triage data and say, yeah, for sure, he's going to get an ultrasound. So could we teach a model to do that? And so what we did was we took our ED triage data, like I had said, things like demographics, vital signs, triage notes, et cetera. This was a retrospective data set, which means we went back in time over 1 year's worth. We had about 77,000 patients. And we prepared that data for ingestion into a machine learning model. There's certain pre-processing maneuvers that you need to do, where how you manipulate the data so that it makes sense to a machine learning model. And we automated a process that could do that. And then we fed them into 3 common types of machine learning models. And what we were doing is we were asking a binary question, which means the model has to tell us it's either A or B, right? It's either the kid needs an ultrasound for appendicitis or doesn't need an ultrasound for appendicitis. And then we rigorously evaluated this with a series of outcome metrics, and we did some explainability and bias testing and whatnot. And so we've taken all of the triage data. Essentially, this is just to say that if there was a data point available at triage, we just took it and processed it, even if we thought it wouldn't be overly useful. It's not necessarily the most sound computer science method, but we didn't want to make any assumptions. So we took it all and we processed it all. We used 3 different types of machine learning algorithms, and these are just common ways of building an automated system, common algorithms. There's one's called logistic regression. This one's called random forest, which is like trying to get the model to make a decision tree. And then there's deep neural network models. And what these models are actually trying to do is create a decision boundary. Like it's trying to create like a line mathematically to say, when I see this type of patient, I'm going to order the ultrasound. And when I see this other kind of patient, I'm not going to order the ultrasound. And so if you think about like, this decision boundary in dogs and cats, a very simple type of machine learning algorithm might be able to draw a straight line like that. You see them not bad. Like we get all of these ones here, but we do have some false positive cases or false negative cases. A more sophisticated machine learning model might actually be able to draw like a curved type of boundary. That's a little bit advantageous, as you can see, because now this one is being classified correctly. Something like a deep neural network model, and this is why this idea of neural networks and deep learning, you're hearing a lot about this, and why this is becoming so attractive, is because a deep neural network decision boundary could possibly be like this. It's a little bit more sophisticated, and it can pick up on some of these nuances to know that, well, that's not a positive case. And so that's the difference in why we're using 3 different types of machine learning techniques, is we always want to use the simplest thing, but sometimes you need something that's a little bit more sophisticated. And so what is a neural network? Because I know we've heard a lot about this. Well, it's named basically off of the anatomy of a neuron. This here is essentially a neuron in a neural network model. You see it looks exactly like our typical neuron, where we have dendrites here that feed into our cell body, right, in the brain. Instead of dendrites, you have data inputs here that feed into the neuron or the cell body of the neural network, so very similar. Here you've got your nucleus, right, that does like, you can maybe think of it as like the genetic processing. Here, similar thing, there's a mathematical function in the middle. We don't need to know what it is today, but essentially that mathematical function is doing processing of the input data that came in, just like what happens in a nucleus. And then you have like an output arm, just like in the brain, where it then sends a signal onward to another neuron. And that's exactly what's happening in this neural network. And so if we look at this may look incredibly complicated, but if you like sort of take a high level overview, it's pretty basic on what's happening. All of these dots here are neurons, right? Just like how we have in the brain. These connections here are, you can think of them as their axons. They're ways that the neurons in the neuron are transferring and communicating information. And essentially we have input data that flows in and travels all the way through here and gets processed until it comes to the end of the network, where it then makes a decision. In this case, it's a cool example where we're deciding, is this, what president is this, I guess is what the model is trying to do. And at each stage of the neural network, these like different layers, you can see how like each one of these is a different layer. At each stage of the neural network, the neurons, they're looking at something different about the image. Like here initially, it's just looking at the pixel color, right? Or the shade. Here we're starting to look at like a bit of the edging here. Here we're starting to look at a bit more like combinations of edges. Like, so here's an eye, for example, I think that's his nose. Here is like, a little bit more pulled back. And then at the end, we'd make a prediction on who the president is. Or in our case, we make a prediction. Do we need abdominal ultrasound? Yes or no? And this is just to show that there's like the flow of data. So for example, back to the cat dog, just replace this with ultrasound, yes, no. Data is flowing into our model, like how it flows into our brain, and it's getting processed by each of the different layers. And we're making then a final prediction at the end here. So here's the initial area under the receiver operator curve, or AUROC curve, for our model's ability to take this triage data and predict, do you need an abdominal ultrasound? Yes or no? And I got really excited when I initially saw this curve, because these numbers are high. They're like close to perfect, but far from it if you actually put this into like a human perspective. And by that I mean, when we look at outcome metrics for our machine learning models, it's really not just like about numbers, which are nice for publication, but you have to think, well, what are the consequences to the humans that may interact with this model? And so an AUROC curve shows you the true positive rate. So for example, this is how many of the actual kids who needed an ultrasound, how many are we capturing, right? And then this is showing the false positive rate. And the reason why that's important is you can imagine if we are letting a model autonomously order tests on kids, we obviously can't have a high false positive rate. I mean, think of what our diagnostic imaging colleagues would say if I just like deployed this and suddenly all these kids were going for ultrasound requests. And so you can kind of see how that would apply on this curve. A machine learning model could actually sit anywhere along this curve and operate. And you can see at these different thresholds, the true positive rate and the false positive rate would differ. So if we said we want to capture every single kid, 100% of who needs an abdominal ultrasound, right? The false positive rate is really high. You can see that here. That's really, really high. So yes, we would never miss a case, but I'm going to be sending hundreds, probably actually thousands of kids who didn't need an ultrasound to diagnostic imaging. No way, this doesn't work. But we could be a little bit more humble and we could say, well, this part of the curve looks nice. It doesn't seem like a big number, but if we were to say, let's even just capture 10% of all the kids who need an abdominal ultrasound. What if we just automated ordering for 10% of them? Because it's kind of a common test that we do. What would the false positive rate be? And here it's really low. And so we're able to optimize an outcome metric called positive predictive value. Really, that just means that you have low false positives. That's what you're trying to optimize to get that number to be high. And so we could sit here, maybe have a really low false positive rate. And then when the false positive rate is so low, maybe it's okay that the model could autonomously order the test. Like maybe that's okay. And if we were to actually do that, for those kids where the model places the order, we would save 162 minutes of that kid waiting for the order to be placed. So maybe there's a way to add efficiency there. Then we started to say, could we do this for other things? And it turns out we can. Like we can do this for forearm x-rays, we could do it for ECG testing, we could do it for urinary testing, which like seems like, oh, well, what's the big deal here? I mean, if you work with children, as all of us do, trying to convince a 2-year-old in the emerge to pee into a cup, like is a whole song and dance, right? It takes a lot of time. So if we knew we needed the urine, getting that started early would be useful. And it's nice not to just get all kids to do the urine testing early, right? So being a little bit more specific with that. We can automate the orders for testicular ultrasound testing. And so if we look back to our workflow and through design thinking methodology and like really, meaningful stakeholder engagement, we can come up with a workflow that actually augments the current standard of care. So go back to that kid with the tummy pain needs an ultrasound, data is put into our EHR. And now if that data flows into our machine learning algorithms and makes a prediction that yes, this kid definitely needs an abdominal ultrasound, we know that we reduce the false positives because we're sitting in that little bottom part of the curve. So we know that when the model fires, it's probably going to be like a positive case. So we'll automate that order. And that kid can go straight to having the order placed with DI and getting an abdominal ultrasound done. Maybe there's dilemmas with doing that. We need to think through that and figure that out with, again, more design thinking methodology. But technically, we could probably do that. For all of the kids where we don't make the prediction when they needed it, well, maybe they could just go down the standard, the standard of care, like the normal process where they wait a little bit. But then if we start doing this, here's the hypothesis that we need to test. This needs to be answered. If we start doing this for all of these different common use cases, like the ECGs, like the urine, like the x-rays, and we're automating fractions of care delivery, would that actually make the system more efficient up top here for the kids that wait for the standard of care? It's going to be interesting. We're going to have to see how bottlenecks and how different flow interactions lead to that. But now there's actually a potential to explore this question, because we can see that our machine learning models do a great job with that. And then we started thinking, well, if we're going to actually automate the ordering of these tests, we kind of need to be able to say something to the family, right? And so we're thinking about, let's imagine there is some sort of interface where our machine learning models can talk to the parents and whatnot. The model needs to know why it's ordering the test. And so this is this idea of we're looking at feature importance, not necessarily for the purpose of validating the model, although it's reassuring when we see the model is thinking like how a human thinks, but more for the purpose of being able to facilitate these communications with families. And so here is this plot, and we're using something called SHAP values. SHAP values are, it's game theory methodology. It's nothing cutting edge. This is from back in the day, in the 60s, I believe. And what it does is it looks at who are all the players that contribute to the outcome of a game. And so in this case, the game is the model's ability to make the prediction, right? The outcome is, did it get the prediction right, yes or no? And the players are all of the features that are going into the model. So we're just like piggybacking on this game theory methodology. And blue here means that the feature is not present. Red here, like here, means that the feature is present. So for example, there was a concern for appendicitis at triage. And these values here, the higher the SHAP value, the more likely the model is going to say, yes, you should get an ultrasound. And then the lower the SHAP value, the more likely it's going to say, no, you don't need an ultrasound. So here it's kind of neat, because like if you see the absence, see how this is blue, so it means not present, the absence of abdominal pain means that the SHAP value is going to be really low. And so the model's going to say, probably don't need an abdominal ultrasound if you don't have abdominal pain. That makes sense, right? Here, if there was concerns for appendicitis in the triage note, because we processed the triage notes, and if there was a concern for appendicitis, then the SHAP value is high and the model moves towards ordering the ultrasound. But this is on a model, like a holistic model perspective. If we're truly to say we want to explain to that patient why they specifically need an abdominal ultrasound or some sort of automated test, right? We need to use that patient's own input features, like why they've come to the emerge. And so there's a way that we can leverage these values on a patient-to-patient level, prediction-to-prediction level, and explain why the model thinks something. Now, we would obviously never be able to show a family this plot. It's even confusing for me sometimes when I look at it, but this is what the model outputs. And essentially it's the same idea. The higher this SHAP value, the more likely an ECG in this case is going to be needed. And so, for example, the reason why the SHAP value is so high, because these features were present. There was some complaints about the chest. There was dyspnea. There was chest pain, right? There were some cardiac features to the chest pain at triage. And so those are the reasons why the model thinks for this specific patient it should order the test. And then we could also do the same. Like often parents want something and we don't order it and we need to explain why. And so the same thing can happen. Here, 0 probability of needing an ECG. The only risk factor in this is real patient data. The only risk factor for this patient was that they simply arrived to our emerge. They did not have issues of chest pain, syncope, etc. So we've got this really cool model. Can we deploy the model to other sites? And let's assume that we've done all the proper validation, prospective validation in at Sickkids, model's working really well. Can I bring the model to Chio? Why or why not? Or to other sort of pediatric sites? And so there is this issue that we all need to be aware of. And some of us, it's maybe intuitive from our other research work, but there is an impact of varying patient distributions on how a model will perform. And so by that, I mean, let's say this is Sickkids and this is our patient distribution. The different columns just represent some sort of maybe demographic features or characteristic features of the population we see. And let's say this is Chio over here, and your distribution is totally skewed in a different way, right? Our machine learning model that's learned in this environment may not, and I could maybe go as far as to say will not, predict very well on this new distribution, because it just doesn't know. Like, we barely saw all of these orange boxes, whatever that represents. And so when we are planning these projects, when you're planning strategy and you're thinking about, okay, maybe we could share the cost, or maybe we could build a national system that makes it more feasible because it's that much higher impact. And just know that, a model trained at one site isn't just going to port over to another necessarily. And so what can we do to overcome that? Because that's what we want, right? We want to begin to connect and break down our health system silos. And it'd be awesome if our Emerge and Chio's Emerge could have a similar type of deployment for these models. So how do we overcome that? Well, one thing maybe we could do is we could just start to pull all our data together and then train the model. And I say just because it's not just, right? There's all of these data governance barriers and privacy barriers that we need to overcome. But I can tell you, it is totally possible within privacy law to facilitate us pooling data together and building a unified model that works both at Sickkids and at Chio. This is something that I'm actually actively exploring right now with Chio. There's another approach, though, that might work really well, and it's this concept called federated learning. A bit experimental still, but the idea here is rather than pooling the different data sets across into one common space, which has some data governance dilemmas associated with it, but key is that can be overcome. We could maybe train separate models, like train a Sickkids model, train a Chio model, and actually just take like the model learnings themselves rather than the raw data, and pool the model learnings together into one final model that might work well. And so maybe this will generalize better. And maybe that would work. The only way I'm going to be able to know that is actually to collaborate and to test both scenarios. And so I'm excited to say that we're actively trying to figure out how we can get our Sickkids AI team and Chio's outstanding research folks to work together to figure out answering that question that I just showed. Should we pool our data together? Could we actually use these federated learning techniques? How will the models perform? And could we then build AI systems that are maybe more feasible to sustain because they're like co-invested and co-maintained? And so this is something I'm really excited about and hoping to formalize in the upcoming weeks. And so if you're part of a data governance committee or part of an RAB committee, you might see me and your colleagues sort of knocking at your door. And so please embrace us with our ideas. There's another quick project that I want to talk about before I dive into some other really important considerations, mainly because this is just something brand new that we're starting, and I'm really excited about it. And it's this project that's around using ocular pediatric ultrasound and combining that with AI. This here is actually just meant to show you that these machine learning projects, like they truly transcend the silos, right? Like I'm an Emerge doc computer scientist. This is a radiologist. We've got a POCUS expert. We've got neurosurgery, ophthalmology, remote medicine, and a bunch of different types of students all coming together on this project and each has very meaningful contributions to figuring out how to build out this workflow. And so like one single AI project just totally transcends silos. It's really cool. And so let's take a really common thing we see that's challenging, and it's around kids with headaches. This again, born from necessity and real patient cases that I've had over the past years around kids coming with headaches. This particular mother saying, my 5-year-old boy headaches all the time. He's stopping play. He didn't have besides stopping play, I suppose, and headaches in a 5-year-old, those are red flags, but he didn't have all the other red flags that immediately get you to order MRI or CT scan. But she went to many, many doctor's visits. Another case, very shortly after, a 17-year-old female with 2 months of on and off headaches thought to be related to stress, screen time, virtual school, and less so an organic pathology. And both of these kids, unfortunately, did have brain tumors. And I remember delivering the news to these families and the parents looking back and saying, we went to so many doctors. Why did this take so long to diagnose? And there's no answer. It's so frustrating. But the reality when you reflect on these cases is that it's hard. It's hard to actually see a very common symptom like headache. We see it all the time. And our system is tasked with picking out the right kid at the right time to do, a resource intensive study like a CT or MRI. And one reason why it's incredibly hard is if you try to take this light and look into that 5-year-old boy's eye and assess for papilledema or raised pressure in the brain, which is a key finding that would make you say, oh yeah, we got to get the scan. It is like near impossible to do that. And so we are not competent at doing that maneuver. And we try to do it, but we're not good at it. And there's a whole body of evidence that, quantitatively demonstrates that we are terrible at doing this. And so we thought, maybe could we improve on this situation by using point of care ultrasound? It's an easier test to perform than fundoscopy. You can put the probe on a kid's eye. They can even have their eye closed, right? And they can be fussing a little bit with it. And you can still actually see the back of the eye. And what we're trying to get is like, here's a normal eye. What we're trying to find is this bump, this marker of optic disc elevation and papilledema is what we're trying to identify. Because these patients, they shouldn't be waiting with headache diaries and Tylenol. These patients should get neuroimaging. Point of care ultrasound is really attractive because rather than this giant machine here, they're starting to become more portable, fit in your pocket literally. And there's all of these like really experimental forms of ultrasound, like these ultrasound patches that, and look how small this one is, that are starting to come out. So there's maybe really cool opportunity for portability and translation. So what we did was we took the ultrasound images. An ultrasound image is essentially like a video clip with many frames in a video. Usually it's about like 60 to 90 frames per clip. We took these clips and we started to feed them through the deep neural network models that I was talking about before, same type of model. And we're doing a classification task or a binary classification task. Just like I said before, we're tasking the model with saying, yes, no. Is there papilledema? Yes or no. That's all the model has to do. So these are just two different techniques where, we try to feed in individual frames into our neural network model. This is like the same thing that we saw with the neural nets and all the circles. This is just a different way of representing it, but same thing. We also tried to take then like a sequence of images together and feed that into the model. Because maybe, one image that comes after another image, maybe the active that it was after that image is more predictive rather than just a still one shot. And so we fed those into machine learning models. And these are some of the initial preliminary results that we won a nice grant with, which is cool. Again, this is an AUROC curve, true positives plotted against the false positives. Pretty nice result, although there is room for opportunity here to improve. And so ideally, this line is over a little bit more. So we're going to work on that. But another really cool thing is that same theme of explainability that I talked about. In the last use case, we were using something called SHAP values. In this case, we're using something called GradCam. It doesn't matter what it's called, but the principle here is that we're really trying to make the machine learning transparent and colorful and explainable so that it's not some just abstract prediction where you then like sort of hang your hat on and need to just blindly trust, but we wanted our models to show the ultrasound image, which is here, and highlight, we asked the model, highlight in red where you think the most concerning part of this image is. And you can see here, it's nicely narrowed in on the posterior retina or the papilledema there. And so that was nice to see. And so from a translation perspective in this project, we've won a grant to try and figure out deployment of this model into a pipeline that would interface with an app. And we want to try and improve on that curve that I was showing by not only feeding in the image to the machine learning model, but also feeding in red flag symptoms like headache, night wakening, vomiting, loss of weight, maybe vision change. We're going to explore what symptoms seem to be most predictive. And we want to be able to build an app where we can toggle on and off these types of symptoms, combine it with the image, and then have the machine learning model make a prediction. Two very exciting use cases that I'm like just super stoked about getting off the ground and deploying. And you can see how these tools would have high impact if we can translate to the bedside. But there are some massive dilemmas to think about. One is around recognizing that our healthcare data sets, as we know, are filled with bias, right? These are just like systemic institutional biases that are latent within our data. And, we often hear, oh, well, AI is no good because it's just going to learn the bias that's in our data. Well, I don't think it means that AI is no good, but the fact there is that it will. The AI is going to learn from our data. And so if we have biased practice, the AI is going to learn that. And so, for example, there was this algorithm that was deployed in the US and actually like influencing patient care. And the way the algorithm worked is that it would predict if you needed critical care access based on like healthcare cost as like the metric that they were using to train the model. So for example, I was using like, did you need an abdominal ultrasound? Yes or no as the label. In this particular model, the label that was utilized was cost. So how much cost has gone into that patient's care historically, right? But here was the problem. The problem is if you were Black in the US, and this is still to this day, and you tried to access care, you actually have more barriers to accessing care. So your healthcare costs are actually lower, like the same population, same dilemma, same problem, but if you were Black, your care costs would be lower. And what ended up happening is the model accidentally learned, right, that if you were Black, you had lower care costs, so you less likely needed critical care. And you know, of course, the inventors of the algorithm, I assume, of course, didn't intend for this to happen. But you could see how this is a sneaky thing, right? Like they're not even necessarily using race as like a feature going into the model or as like a predictive label that they're trying to predict. They're just using health costs, and the logic kind of made sense. Imagine a group of people around a table trying to decide, what are we going to build the model to predict? Oh, well, people who need critical care have higher healthcare costs. Let's just predict that. That all makes sense, right? But what was lacking was that foresight to recognize that not everybody has equal access to that care when they need it. And so this was actually a biased model that was causing harm. And this isn't just like a healthcare dilemma. Like it's not like amateur hour in healthcare. We're trying to do AI and we really have no idea what we're doing. So we end up with these like bias issues. Even leading AI companies like Amazon, for example, they had a model that was helping to screen like the tens of thousands of resumes and applications that come to them. And the model was essentially biased against women. So Amazon lost out on all of that talent because people were female. Like how terrible is that? It sucks for the company and it sucks for the population. And so they had to pull that model. You know, there are other things that have bias that are in our day-to-day tools. Like many of us probably have some form of a smart speaker in their home, right? You know, the Google Home, for example, if you have an accent, the model is less likely to perform well than those who don't. Same thing with Amazon Echo. So if we're starting to leverage these types of predictive tools, you know, because each of these companies have APIs you can plug into it and leverage their AI technology behind these things. If we start to utilize them for healthcare use cases, there is a bias there. You know, here's another one. You know, big companies here using facial recognition technology. And you can see that, you know, if you had darker skin or lighter skin, there was a 12% error. This is still pretty good though. So here's a question, like, is that good enough? Does it matter if someone is 87% and another group of population is 99%? Like maybe that's okay to deploy. Who answers that question if it's okay to deploy? We need to solve like these types of things. You know, the approach that we're taking is who answers it is like a whole group of people, including the patients themselves, right? Stakeholder engagement. But if you actually do a slightly more detailed, robust analysis of these errors, you start to see there's actually a big difference laying underneath the surface. This doesn't look so bad, maybe because they're all in green and maybe they are bad, but this here is a lot more obvious, right? That if you were darker skin and female gender, your error rate was much higher, right? And so imagine if we deployed this model, right? We wouldn't have known that we were causing harm to this group. And so this is just me advocating to say that it's not all about, you know, outcome metrics, you know, your predictive rates and your false positives, true positives. Like this matters because this will be hiding in our algorithms and we need to uncover them. And so really this is a team sport. We need to have EDI experts to help fill these blind spots for us. And we need design thinking experts as part of the table. And when we do our bias assessments on our solutions that we build, if this represents you know, a particular racial group or ethnicity group, of course we can't deploy this model. Or maybe we could. Maybe we only deploy it for these groups and we build a new model for this? I don't know. We need to solve that. Like, what's our approach going to be? Because I could say that there for sure will be these types of biases in our data. It's coming. So we need an approach on how we could derive the value from machine learning while overcoming this limitation. And, I had this assumption, and I think the assumption is probably true, that in Toronto, Ottawa, Canada in particular, we have such a diverse population that I think our algorithms will be incredibly valuable and diverse in their ability to overcome these biases, because we have access to these populations, right? But the problem is that we don't have the ethnicity data. So I have such diverse kids coming into RED, but in my data set, I don't know who is who. So I can't even conduct the proper bias assessment to actually validate that my model hasn't learned these biases. And, if we find a bias, it's not like end of the world, oh my. It's really like, hey, we've uncovered something important. Now let's think about how we overcome that. And there are ways where we can overcome biases with our AI to actually start to propagate further more equitable care delivery. But we can't do it if we don't have this data. So, I heard that, machine learning AI is a strategic vision at Chio, but that vision won't be realized if we don't have the ethnicity data to do these types of assessments. So I've been drumming this beat at Sickkids for a while, and we're trying to fix that and overcome it. And maybe that solution should be something unified between Sickkids and Chio. Other issues, one of the, I don't want to call it evil genius plan, but really the plan for that triaging model that I showed earlier. The reason why we're using triage data, because I actually believe that soon that same type of triage data will be available in the home environment, and that soon maybe we could take that type of model and begin to train it on home data that is very similar to triage data. You can get a parent to type in their complaint and to get some wearable data to make predictions. And so that's really exciting. That's really the end goal of where we're trying to go towards from a disruption perspective. But then it raises issues around, well, access to hardware, right? Like if in order to access some of our algorithms, you need wearable devices or you need smartphones, right? These are some of the actual less expensive ones I was able to find through just Google searching. They're expensive, right? There's this sock here, $400 to get like a continuous oxygen saturation on a young baby. So it's going to create barriers. So we need to have that in our mind. The workflows and the solutions we build need to be accessible, and that's going to be challenging, especially when we're trying to break into the home environment, because there's so many benefits to gain by getting a model into the home. Think back to that use case or that scenario that I told you that really impacted me, where that kiddo had died. The thought here is that if we had a model in that home, could there have been an opportunity for earlier detection to send that family in faster? And so you see the value, like this is driven by a really emotional, like real dilemma. But if we don't have access to hardware, families are going to miss out and we're going to worsen our digital divide. How are we going to solve for that? I don't have an immediate answer. Access to internet is going to be another dilemma as we start to translate models into the home, right? And so here, I think this is a year or two old, but it's probably very similar. This is a national broadband internet service availability map. Basically, it's telling you in the brown dots where there's proper high-speed internet available. And you can see there's massive gaps across the country. Sure, most of us live here and here, not bad. What about the in-between though? Like my dad actually lives right here somewhere. So he doesn't actually have access to proper high-speed internet. And so there's lots of gaps here where if our solutions depend on that connectivity, some patients may be stuck sitting like waiting for their healthcare to load. Think of how impactful that is. We get so frustrated when Netflix like starts to stall, let alone care for your kid that you're worried about. So AI must be for everyone. And in order for us to build these solutions, yes, there's, figuring out the workflows. Yes, there's building models and validating the models. Of course, that has to happen. But there are so many layers around it that we need to simultaneously be working together to solve for so that we can truly make AI for everyone. Thank you so much for the opportunity to be here to talk today. And please reach out anytime to any of my email addresses here. I'm always open to chatting, particularly if you're a resident or a fellow and you're looking to breaking into the AI ML space, or even a young staff or old staff, I guess I should say, like myself, who learned this after the fact. After my training is when I learned computer science and learned how to program these models out. If you're curious about that journey, please reach out anytime, and I'd be happy to take any questions now.
Thanks very much, Devin. Can you hear me?
Yeah.
That was amazing, and your enthusiasm truly palpable and infectious, and really interesting how you intersected AI with, not sure who that is, but interesting how you intersected AI with both personalized precision health as well as EDI, which are issues that are very top of mind currently. So we have time for some questions. Are there any questions? Raise your hand. Malise.
I'm going to sneak my mask off. Thanks so much for an amazing talk, very inspiring. I have a question regarding the emergency department's strategy to enhance the richness of data. What I'm asking specifically, if users are doing unique forms and they're just, free texting data, is your group looking at a possible standardized template for major conditions of interest in order to enhance the different algorithms your team can run?
Yeah. So, and you're bringing up like an important dilemma that we're trying to solve. So if it's all just free text, write something wherever you want to, right? Which is what happens at Triage right now. And actually in our clinical notes, like in Epic, we do have templated sections, but I'm even so guilty at, I'll write what I want, where I want for the most part in that template. And that makes it challenging because then you need to use more sophisticated data processing techniques to understand like what's actually happening, and more like natural language processing techniques. So it makes it a bit more difficult. The flip side is by actually implementing some sort of template, there is possibly a bias that we're introducing to the data. So we overcome issues of variability in data, which maybe contributes to noise in the data set, which would worsen the model's ability to make a prediction. But if we put a template in and we forget some key piece, or the way we flow through the template, doesn't have us making or asking a particular question that ends up being really predictive, and we're losing that signal, that may create this bias in the data set based on that template that then the model doesn't predict as well. Or another issue that we were thinking about on this was, if we had 4 years data without the template, and then the template comes in, is that going to shift the way the data looks in a way that confuses the model? Now, I think the answer to your question, though, is we should strive for better data quality. Absolutely. And I think the process of striving for better data quality, actually, the answer is similar to what you're saying, is standardizing the way we document, making sure that we're capturing the right fields. And the more structured something is, it's way, way easier to then both audit the data, but also like build machine learning models on it. And so are we doing it? Kind of. I actually think that Chio is probably way ahead because you guys had Epic before us. And so we do now have, for example, when concussions come in, I notice now, I know where it came from, but now automatically from a concussion patient, there's all of these concussion-like questions that pop up in my documentation field, right? And so I can see that actually rippling through for different things like appendicitis and whatnot, making sure we're capturing the right data points. Another quick dilemma, though, is that then when you think about translating to another site, if they're not documenting in a similar way, that also might create issues with generalizability. And so it maybe speaks to the value of if Sickkids and Chio are wanting to do these things together, the way we think about data input maybe should be harmonized together as well.
Just a pitch for the work our group is doing. So we're really focused on improving efficiencies and incorporating like evidence-based data capture, and would love to awesome. On a broader scale, but it is all over the place in terms of how people document, how they like to document. Change culture is another big piece, but thanks so much.
No worries. Thanks so much.
Thanks, Malise. We have a number of other questions. Nicholas.
Thanks, Devin. It was a great presentation, and you touched so many topics, and I have a lot of questions. But one thing that recently I've been thinking about, actually not so recently, but for some time, is what you talk about bias. So you discussed this situation where we first look at whether the model predicts differently between, I think it was white and black, but then when you look at it further, you look at the intersectionality with gender, and then all of a sudden you realize that in fact there was some combination of these factors that actually has been the model performs much worse. So you talked about the need of us looking at those kind of other hidden biases, but the question is here is very obvious that you chose those two factors. One is gender, the other is race. So it's the most common factors that people basically looking into discover biases, but why not look at many other ones, age, for example, or whatever else? So is there some kind of conceptual model that we can use, to start thinking about how we're gonna perform these investigations in all of these factors that we should be looking? To me, it looks endless. So I don't know
can
if
feel overwhelming in a sense, right? And so Nicholas, you're like a statistical expert. So I'm humbled knowing who I'm answering this question to. And so really though, that example of just at race or skin tone, and then with gender added, that's, just to be clear, that's not my work. That's work that's done by another research group. But the point was to try and say that we need to look at the right type of bias assessments. But I think you're right, like the approach really needs to be not taking our own assumptions of where bias may be, because we might miss something, and actually building like automated systems, which isn't actually that hard to do, where you say, well, here are a whole bunch of features, age, gender, where you're from, this, and you could just take all of those features and then run the error assessments on, and then actually see where do the biases pop up, right? And maybe there's some intersection between distance traveled and language preferred where there's a bias. And the idea really from the bias assessment is to just uncover and point us towards where there may be issues in our data. I agree with you, it shouldn't be limited to what we assume are the important types of bias, that we should really be looking at many different variables and seeing what generates bias, yes or no, and then seeing if it needs to be acted on or not. I totally agree.
Thanks, Nicholas.
Thank you.
Erica.
Thanks so much for this talk. I found it really, really interesting and enjoyable to hear all of this stuff that's coming on the horizon with Sickkids, and excited that, we are sister hospitals and there's potential for collaboration. I wondered what your experience has been with the integration of your systems into Epic. Have you had difficulties with automating your systems? Because we all know that if we're adding something to the already busy healthcare workflows, it's going to not only be less appreciated, but maybe not as is used as we would intend. And so trying to embed these tools so that it's an automated process, but working with Epic and the challenges that we already have with just getting the system customized for each of our different divisions. Just a comment on sort of pros and pitfalls and strategies that you've had.
Yeah, one of the strategies we've taken, and thank you for the compliment, and I'm glad you enjoyed the question or the chat. One of the approaches we've taken is, let's take the data out of Epic and then put it into our own playground so that it's more in our control on how we use the data and how we action on it. And so what we actually did is we have a system. This is not the ideal system, but because of the issues you just rose, we had to find some sort of solution where we have a automated stream of data that comes out in near real time. So it actually is extracted every 3 minutes. And then we have a backend system that then will compute on it, feed it into a model, and then make the prediction. But to your point around, well, even like in the workflow, people are busy. I think this is why it's important that we are thinking around automating the ordering rather than just the traditional decision support. We wanted to move away from issues with work, alert fatigue and overburdening people with different tasks by deploying technology. And really, if we get to a place where the technology is good enough, could it actually automate the ordering of the ultrasound? It interacts with the patient directly, within the pre-existing workflow, and diagnostic imaging really just receives it, but just receives an order that, hey, here's another ultrasound that needs to be ordered potentially. Like, is there a way that we can start to remove people from the manual steps of deploying and integrating these models? And that's why the workflow was described as is, because you're totally right. Especially right now in our emerge, I'm not going to be able to deploy things that require more human effort. Like, we just don't have the capacity right now.
Thanks, Devin. I know we're basically at time, but I wanted to give the last word to Khaled, who had his hand up. Khaled El Imam, who's our Tier 1 Canada Research Chair in Medical AI. So Khaled.
Thank you very much. Hi, Devin. I had a bit of a follow-up question to the last one. In terms of transferring the models from Sickkids to Chio, have you tried to do that with any hospital? And if not, what do you think is needed to adapt these models? I mean, some kind of transfer learning approach. How would that work in practice? And what are the challenges with that?
Yeah, so the challenges are going to be around exploring what is the best method. And so, because in order to truly explore that, we need a data governance sort of framework in place that allows us to, I believe, pool Sickkids and Chio data together into a common space. The only reason why I'm saying that is because if we were to achieve that, we can then test 3 different versions of how to transfer a model. One around the basic way, pull data together, retrain the model. Let's see what the accuracy ends up being for the outcome metrics on both sides. But the other way, and I think maybe more potential, is around the federated learning system, where we train 2 different models and we bring them together and we see if the learnings from each model actually improves the outcome at each individual site. But the only way to do that, to truly, and I actually think we could do the federated learning pretty easily. And we're working with folks like Nicholas, actually, Mala, Dana, and Ivan at Sickkids, or at Chio, sorry, to think through the deployment of a solution. But if we can bring the data together, we can then actually answer the question, is it better to bring data together? Is federated learning good enough? Do we actually just bring the approach to Chio and totally retrain only on Chio data? And it's just like the modeling approach that's brought over. Do we do transfer learning like you just described, where we only retrain a little bit at you? If we can collaborate together, we can answer what is the best technique, I think. And so that's really what I'm pushing for on the Chio side, is let's get a collaboration and a use case anchored on this going, and let's see what happens. And then it may be like, vice versa, right? There's going to be things that you guys have more data on, more expertise on, that you could port over to Sickkids as well. And so it's really like a mutual symbiotic collaboration that I'm trying to get going.
Well, thanks very much, Khaled. Thanks, Devin, and thanks everyone for staying for a couple of extra minutes. I think this was a fascinating presentation, and a huge thanks to Devin. Obviously, we'll be seeing more of you as we continue to collaborate, and a big thank you to Dana Radhakrishnan, who's the team captain of our data-driven discovery research team and the lead for our bioinformatics core, for recommending Dr. Singh as a speaker. So thanks everyone. The link for CME credit has been put in the chat, and there's also been some other interesting discussion in the chat. Thanks everyone for attending, and have a great day.